Welcome to another edition of the Harton Healthcare Report. Today we're glad to have with us Dr. Tom Phelps, who's actually the medical director for the Sleep Center here at Harton. Glad to have you here today.
Thank you, Stephanie.
When we get back, Dr. Phelps is going to talk to us about sleep.
Mark, you've won just about everything there is to win in racing. What's next?
I'd like more people to know about ER Extra.
The emergency room at Harton Regional Medical Center?
I just want them to get the best care they can get.
That just gets me right here, Mark.
Maybe you'd like to pay them a visit.
ER Extra at Harton Regional Medical Center.
ER Extra. Extra fast, extra easy, extra great.
Yes, over 20 years we established the Sleep Center in Harton in 1991, I believe. So that means we've been there for 21 continuous years with sleep medicine. Sleep medicine is kind of a young medical specialty. It's been around about as long as I have, as far as a discovery that, hey, when you sleep, your brain stays active, and things happen when you sleep. Before that, about 50 years ago, we did not know that. As a matter of fact, we didn't know anything about sleep because we really couldn't test it. Now, the poets talk a lot about sleep, and some scientists talked a lot about sleep, and Aristotle talked a lot about sleep, but they had no way of testing sleep, and no one really could test it until about 1952, 1953. How many of you had a subscription to Life magazine? Life magazine? Oh, really? How about Look? Look magazine. I can remember as a little boy, just a little chap, looking through that because it came weekly, I believe, and I'd cover it every week. And I can just remember this strange new science of sleep and discovery of what the brain is doing in sleep. And this was basically discovered in around 1952, 1953, about the time I was being born. But it didn't get into the media until a little bit later. And the discovery came by a simple observation of a fellow named Bill DeMint, who's still around, guys. He's still around. He was a young resident. I think it was in Detroit. I may be wrong about the place, but he was making rounds one night, and he looked down, and he saw that his patient was asleep, but he saw that her eyes were moving back and forth, and they were asleep, so he didn't, well, this is strange. And about that time, EEGs, electroencephalograms, were being discovered. And so he was kind of dabbling in that as a new kind of resident in neurology. And they put the EEG for the first time on a human being while they were asleep. And Azarinsky and Kleitman, and those are the big names in the discovery of what happens when you go to sleep. And what does happen when you go to sleep? Well, actually, they found out that there were two types of sleep. They wanted to know what was making the eyes go back and forth, and that was REM, rapid eye movement sleep, REMs. Everybody talks about it. It's common lexicon now, but back then that was the discovery. And then they found all the other time when the eyes weren't moving, and they called that non-REM sleep. And they saw patterns emerge, EEG patterns emerge that were different all through the night. And so there really are two types of sleep: rapid eye movement sleep and non-rapid eye movement sleep. And we've kind of refined the non-rapid eye movement sleep to 3 levels: stage 1, stage 2, and stage 3. And stage 3 is slow wave sleep, where delta waves, which are big, tall waves, and slow waves occur. And that's where you get your deepest rest, we find. And that's going to be kind of the subject of a little bit of a talk I give today, is the slow wave sleep. And we've studied human beings and their behaviors the next day, and there are just literally millions of pages of research now on all types of sleep, whether it's slow wave sleep or rapid eye movement sleep, or stage 1, which is just kind of a transition from wake into sleep, and then the majority of adult sleep is stage 2 non-REM sleep. And it has characteristics, and we won't go into that. That's not the purpose. But to talk a little bit about slow wave sleep, which is something important to you. None of you here in today, including me, get much of it. Maybe the photographer back there. Around age 40 or 45, we start to lose our slow wave sleep, and it diminishes, and that's your deep, deep sleep. And that sleep is important to focusing memory and transferring memory from short-term memory to the parietal area, which stores long-term memory. It's also important in covering or building tolerance to pain. They did a little experiment, not a little one, a huge experiment. You can do this all day long, and they would measure one's sleep the night before with a polysomnogram, which is a sleep test, which means many tests while you sleep. And they found that people with slow wave sleep had a greater tendency to tolerate pain the next day. We had a little instrument of torture, which is a little heat lamp, and they would stick their index finger in it, and then they would stop as soon as they started it. That started the timer, and then how long did it take for them to say, "Oh, that hurts," and then jerk their finger out, and they found that a very statistically significant difference in the pain tolerance of people who had slow wave sleep. So, yes, ma'am. Slow wave sleep. Wave, W-A-V-E. Because we're talking about EEG waves and that sort of thing. But it's also called deep sleep. So deep sleep seems to be important to pain tolerance. And I've noticed that ever since I was around 50, I wake up with an ache or pain, and I have a ache or pain. And so it's about the time that we start kind of hurting from arthritis, and our body's starting to hurt us a little bit for no apparent reason. It's about the time that we also start losing our slow wave sleep. So that's kind of important. That's one thing that's how our sleep is a bit different as we grow older than when we are younger. Indeed, if you take rapid eye movement sleep or REM stage sleep, we all have normally about 20% of our sleep in rapid eye from about age 2 or 3 all the way until 100. So REM stage sleep seems to be a constant, whereas slow wave sleep seems to kind of peter out as we grow older. So that's kind of one way we do it. With that kind of change, we believe, then we have kind of a change in how we sleep as well. One tendency is to go to bed with the chickens and get up with the chickens, if you know what I mean. If you've country folks, you know exactly what that means. I have chickens. I do know what that means. I had a rooster, but I shot him. We really didn't need that rooster to wake us up 3 o'clock in the morning. So and that's kind of how we do. We start having less of a propensity to stay awake and more of a propensity to sleep earlier and earlier. And that does set up for problems in society when you're going to sleep at 7 o'clock or getting sleepy at 7 o'clock. Oh, lo and behold, you wake up at 2 o'clock in the morning and wonder, well, what do I do now? Does that happen to you? It happens to me from time to time. Yeah. Whereas in teenagers, if you have some grandchildren who are about 17, they are not human. They are not human. No, they're not human. They're bats or maybe raccoons or skunks, maybe, because they like to stay up all night. And normally, that's basically what older teenagers and college-age people do. They have a propensity to push back sleep, and actually, that's actually a norm. I see some teachers in here, and you probably hated to teach first period and second period in high school because nobody learned anything because they just couldn't get up and get to class on time half the time, and if they did, they were pretty vegetative. So that's a problem. And as a matter of fact, Mary Karskaden, a little lady about this tall, great researcher, did all the normative research on teenage sleep. And what she found out is exactly that. Their most awake time is those hours that most of us are very, very sleepy, just diametrically opposite. So they stay up until 1 or 2 o'clock in the morning. Why? Because they're not sleepy. And they just aren't sleepy. But that causes a problem. If they need 7 or 8 or actually 9 hours of sleep, well, they should be sleeping through 10 o'clock the next morning, and of course they got to get up and go to school. So there's a struggle that you probably did meet as parents, and actually it is a norm. As a matter of fact, in Detroit, they set school start times back an hour for the high schools, and just kept them till 4 o'clock. SAT scores, ACT scores skyrocketed. They didn't make any difference at all. They got another hour or 2 of learning in the morning, and it made all the difference. So that's kind of something we ought to look at when we have good science to look at. Probably ought to change bad behaviors or some behaviors that we just because that's traditionally the school time. So that's kind of the circadian rhythm of young and old. And so the rest of my talk or our questions will be probably about insomnia, which is probably what affects almost everyone in here. At least 35% of you have some non-restorative sleep where you have awakenings in the late night, middle of the night, or trying to get to sleep can be a problem. Although that's less of a problem in people over 50 than under 50. In other words, you can get to sleep just fine, usually. It's staying asleep that is the real problem. I'm seeing a lot of heads go up and down, and me too, and there's a lot of factors to that, and pain is one of those that we might want to answer some questions about and talk about also. So I can open the floor to questions now, if you wish, or if you want to just talk about any subjects that you know about sleep or would like to have some questions. Yes, ma'am.
If someone is sleeping through the night and they're not attuned to any noise, nothing bothers them, is that considered a deep sleep?
It's continuous sleep. It's probably restorative sleep. Wouldn't know unless we actually tested it. But the fact that you go to sleep within 10, 15 minutes is a normal. You wake up and you don't remember anything, you're blessed. We have no memory of anything while we sleep. The brain does not record memory except the hallucinations we call dreams. We may remember them, and some people remember them better than others, but we all dream. But you may remember a dream, but you won't remember anything that went on. Now, if a person wakes up enough during the night, they may have the opinion they didn't sleep at all. And we have had patients who've gone through the polysomnography who have refused to pay us because I didn't sleep last night. They may have had 5 hours of sleep, but they were awake 2 or 3 hours. And what they remember, what their brain records is that, well, they were awake a lot of the time that night. And yet we know what electrical sleep is, and they do sleep, they just have no memory of it. But if you wake up and you have no memory of it except when you went to sleep last night, that's the holy grail of sleep is to sleep like that, a good solid night. Unfortunately, it's more rare than that. But I think that, there are those people who do that, but I think it's probably only about 30 or 40% of the population over 50. Any other questions? Yes, sir.
When you wake up frequently at 3 in the morning, what you going to do?
Well, excellent question, and something that occurs to almost all of us, some of us very habitually. And what we would like to know is why that's happening. Is it pain? Is it your bladder wanting you to get up? Is it that you went to bed too early and yes, you've gotten your sleep and it's time to wake up and your brain has saturated, it's well slept, so it wakes up and you're ready to go. Some people just don't like sleep. They wake up and boy, they're ready to go at 3 o'clock and they're ready to get on with the day. That's me. I like it. I like to get up at 4 o'clock in the morning because it's quiet. My wife's still asleep, and I can read, I can write, and I can think without interruption. And so I've kind of gotten in the habit of early morning arising. Not everybody does that, but I've seen a lot of very goal-directed people who just can't get past 3 o'clock, 4 o'clock in the morning many times. So what do you do? That's a good question. What do you do? There's a number of different things. The first thing is to keep good sleep hygiene. The worst thing you can do is sit there frustrated, flipping and flopping in bed and watching your clock. And every 3 minutes you say, oh gosh, it's 3:30. I'm not going to be any good tomorrow. And this is terrible. And to get frustrated. Our usual standard advice is to get out of bed, go to somewhere else in the house, maybe a nice comfortable chair with a backlight, not a light that's grown, not a computer, not a television that wakes you up, but something, a backlit lamp, and pick up something that's really dull and boring. The Encyclopedia Britannica, read Leviticus, I don't know. It's something that you're just not terribly enthralled with. Not a John Grisham novel, please. That's not what you want to do. But something that you can kind of relax with and go, when you feel yourself, nodding off and getting sleepy, then return to your bed and continue your night of sleep if you can. So that's the standard advice. A lot of doctors will give hypnotic medications. That means a sleeping pill. I tend to try my best to stay away from that because it really doesn't treat the problem. It just treats the symptom. And the problem may be a circadian rhythm disorder. It might be sleep apnea. It might be restless leg syndrome. It might be your bladder. It may be in pain. And I like to try to do my best to find out what that is. And we can actually see some footprints of pain in the EEG during a sleep test, for instance. So sometimes a sleep test is necessary, especially when it's a real trouble maintaining your sleep and it is having the adverse effect of daytime sleepiness. Sometimes we would do a sleep test to find, well, what is waking that person up? But hey, if they've just had a knee operation 3 weeks ago and they're still having a lot of pain, or if they have a significant arthritis, it's significant, and you would ask them, because they would know whether they're having pain, you said, well, are you having pain? Are you experiencing pain when you wake up? Yes, no. And so one thing I do as a sleep physician is ask a lot of questions. I have a 2-page summary of questions that I give patients, and out of that is it kind of picks apart what's kind of bothering the patient. They may not realize it, but when they answer the questions, it's kind of evident that that the people are, well, it's pain. And sometimes you've got to rule out everything else because you can't see pain. They just experience it. But sometimes they can tell that to you too. And sometimes it's just waking up because as we grow older, our sleep does become more fragmented, meaning that we have more fragmentation in the stages of sleep. We get bounce in and out of 3 and 2 or 1 and 2 non-REM, or bounce in and out of REM state sleep. And we wake up more often as well. So, and that's a norm. And so it's been the mantra to say, naps before 70 are probably pathological. Another person is more sleepy than they need to be. Naps after 70, on the other hand, are permissible because of that natural fragmentation that does occur to most citizens over 70. So napping can be very abnormal in the younger age. Yes, ma'am.
Would your diet also affect that, the way that you might?
We do advise that you stay away from spicy food toward bedtime and try to eat your meal a good long time before you go to bed. That you not imbibe in alcohol right before you go to bed. Yes, it will put you to sleep, but yes, it will wake you up later on, and your eyes are just, taped open, and you cannot get back to sleep. And because when alcohol metabolizes, then it's going to cause an awakening. Formaldehyde, formic acid, the kind of metabolites that you see of ethanol. So that kind of wakes you up. Stephanie was mentioning chocolate. Probably not a good idea right before bed because chocolate has caffeine in it. And caffeine is just almost as ubiquitous in our diet these days as sugar. I mean, it's just everywhere in there. So you have to check foods and medicines because many pain medications have, guess what? Caffeine as a major ingredient. And so you might take it thinking, well, this is going to help me, but the acetaminophen or the Excedrin, I think, has a lot of caffeine in it, and you're wanting to sleep through the night, not ache, and that's a good idea, but that caffeine might go to waking you up. So you need to kind of read the labels. Everything, we ought to read the labels, and thank goodness we have truth in labeling laws that protect us there. Yes?
If a person is on a CPAP and they start snoring again, does it mean they need to up the flow of the air, or they need a different kind of mask?
Either or. Now, what she said, if a person is wearing CPAP, which is continuous positive airway pressure, that's just an acronym for that, and this pressurizes the airway so that it's always open and never collapsing. And we have just a mask with a little blower about the size of these things now, and it creates a positive pressure in the airway. You shouldn't snore on one of these because the airway is propped open, so it won't vibrate, and it should be propped open enough so that air will pass without the high velocity that causes snoring, and it kind of stabilizes the tissues also. So it's not normal to be snoring under CPAP. It's not normal to be snoring without CPAP, but almost everybody does one time or another, including me. So it's it may be a sign that the pressure is not enough. Maybe one has gained weight, lost tone in the muscles. And maybe it's the mask. More often, it's the mask. The mask has gotten old. The plastic doesn't seal to the face very well, and leaks are occurring, and so pressure drops occur because of the mask leak. So that's most often what's going on. We generally change the mask, or we just get a new mask and make sure that that's okay. There's no reason usually to restudy a person. Now, I know how many of you have heard of CPAP and sleep apnea? Just about everyone. Well, I can tell you, when we started 21 years ago, nobody in this room had heard it, and we hadn't heard much about it either. So in 21 years, it's gotten to be just common, and that's because so many people need it. And I think, yes, it is a very effective and wonderful treatment that doesn't make you to have surgery or make you have to take pills or medications. It's just simply pressure. And you've probably seen in cartoons and maybe some funny sitcoms, a lampoon of sleep test and sleep mask and what they look like. Well, there is the most recent. If any of you wear these, this is amazing. I call it the bikini. And this all inflates around the nose and blows the pressure right up the nose. And you can put it on in about a half a second. And that's all there is to it. It's almost like having just oxygen, but it just pressurizes the airway. So we've come a long way in the process of CPAP as far as comfort, efficacy, and being able to test well for it and see what's going on with it. So every once in a while we like, because it's a treatment, not a cure, we like people to come back and see us if they're having problems, and then we kind of decide what the best thing to do, and we have a variety of things and changes to do. So, yes, sir?
How does that compare to the dental devices that move the jaw?
That's an excellent, excellent question. Most dental devices are only good for mild, maybe moderate obstructive sleep apnea. When I say mild, moderate, and severe, I'm talking about how many times an hour a person wakes up and has a breathing event, and how low do they go when they desaturate, although some of them don't desaturate at all. But in severe cases, which is above 35, 40 per hour, 40 events per hour, dental devices just don't work on very many people. On mild, well, yes, they work on nearly everyone. And I think it's a very good treatment plan for many people. That's right. It can be a little pricey. There are insurance issues with it. That's the only thing. But if those are not a big deal with that can certainly work for that. There are 2 dentists in this area that I'm aware of that are well trained in dental sleep medicine, and that's Michael Long over on East Lincoln, and there is Garrett Orr down in Winchester, Tennessee, and he's young, right out of the military, and he was really well trained in what was going on too. There may be others, but I'm not aware of them.
Mark, you've won just about everything there is to win in racing. What's next?
I'd like more people to know about ER Extra.
The emergency room at Harton Regional Medical Center?
I just want them to get the best care they can get.
That just gets me right here, Mark.
Maybe you'd like to pay them a visit.
ER Extra at Harton Regional Medical Center.
ER Extra. Extra fast, extra easy, extra great.
There's one place women of all ages can find the care they need, the Women's Center at Harton Regional Medical Center. We're a full-service women's center with comprehensive obstetrical and gynecological surgery. Our excellent customer satisfaction rate is a reflection of our commitment to excellence. To serve you even better, we've now remodeled our facility. Our family-friendly birth center features private labor, delivery, and recovery suites. For every stage of your life, we're there for you. The Women's Center at Harton Regional Medical Center.
Dr. Phelps, thank you for being here with us today.
Thank you, Stephanie. It was
Great
my
presentation, as always. Stay tuned for another edition of the Harton Healthcare Report. Thank you.